The background is that we know that there is a high rate of CNS involvement in women with metastatic HER2-positive breast cancer. Certainly from some of the early studies from the Dana-Farber and indeed some of the retrospective reviews from the United Kingdom, it would suggest that anything in the order of 25 to 45% of patients with HER2-positive metastatic breast cancer may develop brain metastases. We know from the adjuvant trial that has probably reported the information most accurately, which was done from the HERA study, that up to 50% of patients who die following a recurrence of their HER2 metastatic breast cancer die with CNS metastases. So this is clearly an important clinical area of concern for our patients. So let me introduce the agent that has come into play for this particular clinical entity in HER2-positive breast cancer. Tucatinib is a HER2-selective tyrosine kinase inhibitor. It is an oral small molecule and shows high specificity for anti-HER2 blockade with minimal inhibition of the EGFR receptor, which relates to the lower rates of EGFR toxicity. From early phase 1 studies, we know that there is good CNS penetration, and as well as that, we are aware that when combined with capecitabine or trastuzumab, that patients overall tolerate this combination extremely well. The HER2-CLIMB study was an international trial, phase 2 in study design, which randomized patients with HER2-positive metastatic breast cancer in a double-blind placebo-controlled fashion to receive tucatinib or placebo together with trastuzumab and capecitabine. Patients were randomized in a 2-to-1 ratio for tucatinib versus the placebo. The primary endpoint for the study was to evaluate the progression-free survival in patients who had previously received taxanes, pertuzumab, TDM1 prior to entry into this study. And the study had important secondary endpoints, including overall survival, as well as progression-free survival and overall survival in the cohort of patients with known CNS disease. Importantly, this study recruited a large number of patients with CNS disease, and patients were permitted to enter with either treated and stable CNS disease, but importantly, patients with progressive CNS disease where the treating clinician didn't require the patient to have immediate CNS therapy was also permitted to enter the study. A small proportion of the patients were also entered into the study having newly diagnosed CNS disease and had not received any CNS-targeted treatment. The primary endpoint population comprised of the 420 patients that were recruited, and this Kaplan-Meier curve clearly shows that the primary endpoint was achieved with a significantly improved median progression-free survival favoring the tucatinib arm and a hazard ratio of 0.54, indicating a statistically significant lower likelihood of a progression event. In terms of the overall survival, this included the total population, which comprised of more than 600 patients. And as you can see, there was early separation in the curves. And again, the group of patients that received tucatinib in combination with trastuzumab and capecitabine derived a significant longer median duration of overall survival and a statistically significant improvement in terms of the hazard ratio for mortality. Of greatest interest was the results pertaining to the patients with brain metastases. Just under 50% of the patients recruited to the study had CNS disease. And you can see from this Kaplan-Meier curve that the progression-free survival in the patients with brain metastases again favored the patients who received tucatinib, early separation with a very significant improvement in terms of median duration of PFS control with a hazard ratio that was statistically significant with a p-value of 0.001. Indeed, at the 12-month evaluation, 24% of patients were still alive, having received tucatinib, whilst there were no survivors in the control arm who received trastuzumab and capecitabine. The tolerability of tucatinib in this large phase 2 study really reflected the earlier studies indicating that the most common side effects with tucatinib were largely diarrhea, hand-foot syndrome, nausea, and fatigue. The majority of these patients experienced grade 1 and 2 toxicity, bearing in mind that there wasn't a mandated antidiarrheal prophylaxis for these patients, and indeed interruption of the drug treatment together with active antidiarrheal medication allowed most patients to recover very quickly. There is some evidence that there is a risk for hepatic toxicity, so it's important that when patients are receiving tucatinib, that blood test assessment of liver function should be monitored. More rarely, there is also some evidence that it can cause a rise in creatinine, although this is not considered to be a clinically significant toxicity, as it does not impact on renal function per se. So given that this is a worldwide collaboration in terms of how we deal with HER2-positive breast cancer, I would just like to share some snapshot concerns with patients receiving treatment for HER2-positive metastatic breast cancer in Australia. So first of all, in Australia, it's important to recognise that over half of the patients are actually cared for within the private sector, where the cost of parenteral treatments and inpatient care is largely covered by private health insurers, whilst patients who receive treatment in the public hospital system have very little out-of-pocket costs involved. Because of this, there can be some differences in the lead time to accessing the initial oncology assessment and treatment for medical oncology services. In virtually every centre, both public and private, there is the multidisciplinary specialty approach. So I think it's important to say that irrespective of where patients are treated, we very much recognise the importance of the different disciplines, both from medical, surgical, radiation, as well as from supportive means from breast nurses, psychologists, geneticists. The guidelines that clinicians follow in terms of managing metastatic breast cancer are largely in line with the ESMO International Guidelines for Advanced Breast Cancer, and this pertains to both multidisciplinary care, the choices and sequences of drugs used in treating patients, as well as the general supportive symptom control, as well as quality of life support. The challenges I think that we face for the treatment of all cancers, but in particular with the very fast-moving pace of therapeutics that are available for HER2-positive metastatic breast cancer, is the time required for health regulators to give approval for reimbursement of medications. Now, for some patients, there will be the ability to access these drugs through self-funding, but many of these are high-cost drugs which will not be available and accessible by all patients. There are also the challenges in Australia of the wide expanse of the country, and many patients reside in rural or remote regions, leading sometimes to difficulties in accessing multidisciplinary breast cancer care, as well as time taken to travel to sites of treatment. We're very fortunate that many hospitals, both in the public and private hospital setting, have access to clinical trials, and clearly patients being recommended for clinical trials is something that is very much endorsed and encouraged, as this is a means by which patients may have access to potentially effective drugs without the need for cost support. And I think lastly, in Australia, we have a very large consumer representation, and this is certainly beneficial for patients as it provides ongoing support and education to women and their families as to what can be achieved in terms of managing metastatic breast cancer. And I think this is a great bonus to women facing metastatic breast cancer in this country. So with that, I will complete my section and I will send this back to Sarah.
Well, thank you so much, Arlene, and it was a delight to have you with us today, as well as everyone else on the panel. Our group discussion is coming up in a moment, but first let's touch on a few future prospects in the area of HER2-positive disease. One molecule, SYD985, is being evaluated in a phase 3 clinical trial called TULIP against standard of care therapy. This is an exciting molecule that's shown promise in phase 1 testing. There are other antibody-drug conjugates also being evaluated, as well as immune-based therapies and CDK4/6 inhibitors for HER2-positive disease. So it's indeed a very exciting time. So let's start our faculty discussion. I should first mention that Grace is currently doing well on TDXD. After 2 cycles, she had a partial response in the liver lesions, and after 4 cycles, had a complete response in the liver lesions, and is tolerating therapy quite well with no evidence of interstitial lung disease. Okay, time for Q&A. Let me open it up to the panel for questions and comments, and please feel free to direct your question to a specific panelist. Yes, Carlos.
I have a question to Arlene. Arlene, with the evidence that you presented on the HER2 CLIMB study, very significant results and very positive results, significant efficacy, particularly in patients with CNS metastases, would you consider using the combination of tucatinib, trastuzumab, and capecitabine earlier in patients particularly that have CNS disease?
So, Carlos, I'm very happy to answer this question. The first thing I would say is that having discussed the results of the HER2 CLIMB study is to just highlight how important the study really is in giving us evidence base for how to manage patients with HER2-positive breast cancer and CNS disease. So certainly this was the most important prospective randomized trial that included the largest population of patients with CNS disease. As I said, 48% of patients recruited to the HER2 CLIMB study had indeed CNS disease that was stable as assessed by the treating clinician. And to see results which support a statistically significant improvement in this cohort of patients within HER2 CLIMB for a significant benefit in both progression-free survival and overall survival makes this a unique result for this drug combination. So the short answer to your question is that in a patient who presents with HER2 metastatic breast cancer with primarily CNS disease and perhaps minimal extracranial disease, there would be some interest in considering using tucatinib in an earlier line of treatment, remembering that those patients entered into the HER2 CLIMB study had already previously received pertuzumab, a taxane, and TDM1. However, as we like to be evidence-based before utilizing agents, it would certainly be important to look at the results that we're shortly going to see as tucatinib is being evaluated in an earlier line setting in one of the studies that are evaluating the combination of TDM1 and tucatinib versus TDM1 with placebo. And certainly the results from this study will be very informative as to whether tucatinib should be utilized in an earlier line of study. But I think it's also important to recognize that in both the pivotal trials that establish pertuzumab in combination with trastuzumab and a taxane in the first-line setting, that in a retrospective review of patients who subsequently developed CNS disease, one still saw a statistically significant superiority in overall survival for those patients who were randomized to pertuzumab initially. Similarly, in the Amelia study that evaluated TDM1 as compared to lapatinib capecitabine, in those patients who developed CNS progression, for those patients who had CNS disease at baseline, or indeed CNS new disease as a site of progression on trial, again, the patients that were randomized to TDM1 had a significantly superior progression-free survival, suggesting that both in the pertuzumab trial and the TDM trial, despite both of these agents not being considered as entering into the CNS, they still provided survival benefits for the patients. So whether we can see a first-line setting trial that evaluates tucatinib versus pertuzumab, that will really show to us as clinicians when to best place tucatinib for patients who we are worried that will develop CNS disease remains to be seen.
Thank you, Arlene. And actually, while we're on the subject of TKIs, Carlos, in Brazil, do you have access to neratinib, lapatinib, and tucatinib? Assuming you have more than one available, how do you choose among the different TKIs? And when do you use a TKI in the metastatic setting? How is your strategy influenced by toxicity, efficacy, or cost of the agents available?
Thank you for this question. This is very interesting. Unfortunately, in Brazil, we only have access to lapatinib, okay? But I think that this question of addressing which TKI is better in the metastatic setting, I guess should be guided, obviously, by two main reasons. The first one is efficacy. And in that regard, the results that were presented on the HER2 CLIMB study put probably tucatinib as the preferred TKI in that kind of setting. Obviously, that doesn't take away the possibility of using some of the other drugs in later lines of therapy, but certainly tucatinib, in terms of efficacy, seems to be the preferred agent among the available TKIs. The other aspect that I think it's important while selecting one versus the other is the toxicity associated with the treatment. All of these drugs have some toxicities to consider, and in that regard, I believe that probably tucatinib, in the combination that was used with trastuzumab and capecitabine, represents a fair choice to treat patients in this kind of situation.
Thank you, Carlos. I'd like to ask Dr. Mutebi a question now. Miriam, how do you manage metastatic HER2-positive breast cancer after progression on first-line therapy? Do you have access to and have funding available for continued HER2-directed treatments such as trastuzumab plus a different chemotherapy or even TDM1? You mentioned most patients need to pay out of pocket, so are there regimens that are more affordable and available to patients in this situation?
Thanks, Dr. Hurwitz. That's a very good question. I would say it's been a challenge. It has been a challenge managing our metastatic HER2-positive breast cancers, especially because of the concerns we've talked about around access. What happens is that patients frequently have to pay out of pocket for these therapies, and there have been a number of access programs that have been done in partnership with pharma and the Ministry of Health. But the challenge behind these programs is, one, the consistency and the sustainability of these programs. And so we're having to think creatively about long-term, how can we continue to provide care for these patients? What it sometimes does involve is looking at biosimilars that are available. They're still biosimilars are available, but they're not necessarily cheap. They are cheaper, but they still have a considerable cost implication to patients. We're also having to look at, especially for patients who are not able to access specifically targeted HER2-targeted therapies, we have to look at if the patient is primarily has a primarily hormone-positive tumor, then looking at what other drugs we can have in our armamentarium and try and exhaust the spectrum of hormone-positive therapies and look at perhaps different lines of single-line monotherapies that may help to at least mitigate some of the disease progression for our patients. But it is indeed a challenge, and we are having to look at how best can we make these regimens and these drugs available to our patients. Thank you.
Thank you, Miriam. You have a question for one of our panelists?
Thanks. I have a question for Dr. Sang. And I don't know if you're seeing something similar in Hong Kong, but we've taken a real hit with the pandemic, because what's happened is we've seen a slowing down of services and the lack of prioritization of non-communicable diseases and cancers. And so my question to you is, how have you been handling the situation, and how have you been able to ensure care delivery even in the midst of a pandemic?
I think that's very timely. I think this is a global challenge for all of us. So basically with COVID-19, especially now at the very moment, we are having our fourth wave of the virus. And so we are practicing social distancing in a very strict manner. So of course, for early breast cancer patients, they are coming back actually on schedule. But same for our metastatic disease, we are very thankful, probably because Hong Kong is still a tiny place and we're very closely connected together, and people actually live not far away. So at the moment, we are still able to offer treatment to our metastatic disease patients, including the HER2-positive disease patients, on a timely manner in rhythm for their cycles. So at the moment, there's not much delay in terms of treatment or treatment cycles. We are also doing something new for some of our geriatric oncology patients, like our elderly patients living with breast cancer. And they might be more concerned about the risk of having infection. So we are actually also practicing telemedicine for highly selective patients. These are more early stage disease who are breast cancer survivors or more on oral drugs that they have been well. So we are able to provide this at our Hong Kong U Private Hospital. So the patients could just ring in with their mobile phones or computers, and then we do the consultation through the internet, and we can then provide medication courier to them the next day with the help of the hospital colleagues. So this is something that's new but seems very acceptable to patients. So I would say, like all of us as oncologists, we are all positive characters dealing with malignancies. So when there are crises, there are opportunities.
Thank you, Dr. Sang. Certainly, COVID-19 is something we are all going to continue to face in 2021. Arlene, you had a question.
So, Sarah, there's a question just I would have in terms of this exciting space of treatment for HER2-positive breast cancer. Given that we have so many new agents, particularly anti-HER2 antibodies, new tyrosine kinase inhibitors, bispecific antibodies, and some of the new antibody drug conjugates, two questions. How would you see the conduct of clinical trials as to how to position these newer agents within the context of what we know is available for HER2-positive metastatic breast cancer at present, given the solid standing that we have for using pertuzumab, trastuzumab, and taxane in the first-line setting and TDM1 in the second-line setting? The second question I have, also in the same vein, is given that a growing population of patients will have received pertuzumab and potentially TDM1 and neratinib in the adjuvant setting, how would you see the positioning of clinical research to identify the most effective drugs if and when patients develop metastatic recurrence, having received these other agents already in the adjuvant setting?
Arlene, thank you so much. Those are two very challenging but important questions that you have raised. For the first question, I would state that the first-line standard of care remains THP, and I'm not aware of a clinical trial yet that is threatening to move the first-line standard of care. However, the second-line setting, there are several trials looking at TDM1 and comparing it to a new treatment, for example, trastuzumab deruxtecan or tucatinib plus TDM1. So I think in the next few years, we may actually have a new second-line standard of care therapy available. In terms of your second question, that's even more complex. You are so correct that there are now 4 available HER2-targeted therapies in some countries for patients with early-stage HER2-positive breast cancer. And because of the widespread use of these agents for patients with high-risk disease, we are seeing a drop in the percentage of patients who are having recurrence. In fact, we're seeing a rise in the rate of de novo metastatic breast cancer because it's possible or probable that a lot of patients are being cured in the early-stage setting. That said, there are still patients who will have disease recurrence that's metastatic after receiving standard of care therapy, and we are going to need a lot of clinical trials to address how to best sequence the agents that we have available in that setting. So let me loop Dr. Crown into the discussion. John, can you share what your group is working on with regard to HER2-altered or HER2-amplified breast cancer right now?
Well, in our laboratory group, we've had a long track record of investigation in the areas of HER2 therapeutics, and we've been particularly interested in resistance to HER2 therapeutics and trying to overcome it with novel strategies. And at the moment, we're particularly interested in a combination which Dr. Neil Conlon and Dr. Dennis Collins have been studying in our lab, both in vitro and in vivo, for the combination of neratinib with dasatinib, which has shown very prominent activity in overcoming resistance in cell lines that were deliberately cultured for a resistance phenotype. We've also been very interested in the idea of trying to improve first-line therapy. And our own translational work in our clinical trial called the Caroline-1 study is studying the addition of neratinib to the dual antibody therapy of trastuzumab and pertuzumab following completion of chemotherapy in patients who are undergoing first-line treatment for HER2-altered metastatic breast cancer. Obviously, neratinib can have gastrointestinal toxicity, so we have deliberately designed the study to isolate it from the early chemotherapy phase. Most patients in the first-line treatment of HER2-positive disease will get a taxane together with pertuzumab and trastuzumab, and after a while, the taxane will be discontinued and the antibodies continued until progression. In our study, at that stage, when the chemotherapy is stopped, we add neratinib, and we're currently exploring this in a phase 1 dose escalation study.
Thank you, Dr. Crown. We'll have to stay tuned. Well, we're about out of time, so I would like to thank my colleagues again for being a part of our global forum today. We are indeed making significant progress in managing HER2-positive breast cancer, and it's an exciting time to be working toward better access to care and improved outcomes for our patients with breast cancer. I look forward to future collaborations with all of you. And to our audience, thank you so much for joining us. I hope the information presented today is helpful to the care of patients in your own practice. To receive CME or CE credit, please complete the evaluation and post-test. Thank you.